Okay, as we mentioned before, um, this fluid between the lungs, between the pleura, is very important. This fluid has surface tension. If you remember back in the chemistry portion of the class, we talked about the fact that water has a certain amount of surface tension. What happens is that the lungs are not actually attached to your chest wall. Um, and what we do is we expand the chest wall, and the surface tension of the fluid between the chest wall and the lungs drags the lungs to inflate them in such a way that we can draw air in. So that's very important. And if we get an opening into the cavity, that is, if there were an injury that allowed air in between those pleural and visceral layers, what would end up happening is the lung would collapse and you wouldn't be able to breathe. Now, looking at again at lungs, if you can see here, this enlarged area, it shows the parietal and visceral pleura, and we have a little layer of fluid in between. Now, when we get to the respiratory tree, what we've said is we already had the primary bronchi. That's the right and the left. Then we have secondary bronchi, which go to the lobes. Those secondary bronchi then turn to tertiary bronchi, just more and more branches, which is why we call it a respiratory tree. Um, those tertiary bronchi go to bronchioles, which then go to terminal bronchioles. Then on the next screen, we see that those terminal bronchioles go to respiratory bronchioles, alveolar ducts, and ultimately to the alveoli located within the alveolar sac. So you should know what comes next: primary bronchi, secondary, tertiary bronchioles, terminal bronchioles, and then respiratory bronchioles and alveolar duct alveoli. Now, the respiratory zone itself, the only site that we have gas exchange is in the alveoli, but we consider the respiratory zone those respiratory bronchioles, alveolar ducts, and alveolar sacs. The alveoli are located within the alveolar sacs. None of the gases exchange anywhere except in those alveoli. Now, this is a view of the alveoli, and you can see, to me, it almost looks like a blown up image of a watermelon, but you can see these are the individual alveoli within a sac. Now, those alveoli are very thin. Um, that's so that we can have easy gas exchange, because it all happens through the process of diffusion. So we need very thin layers. The alveoli are then lined with simple squamous epithelium. There are pores that go in between the alveoli, and lots of capillaries that cover the surface so that they can pick up the oxygen. So what we see is something that looks like this. Here's an alveoli. You can see little pores that will connect the alveoli to each other. Lots of blood vessels scattered about. And a couple of cells types that we'll talk about that are very important in terms of maintaining the integrity of the lungs and maintaining our health. Again, what happens here is gas exchange, and we go from an area of high concentration to an area of low concentration. So there's more oxygen in our lungs than in our bloodstream. There's more carbon dioxide in our bloodstream than in our lungs, and we exchange gases there. Now, as I said before, gas exchange occurs through the process of diffusion. So oxygen enters the blood, carbon dioxide enters the alveoli. Within the alveoli, we have a couple of types of cells. We have macrophages that wander around and pick up anything that gets in our lungs. Every time I take a breath, I'm bringing in dust particles, I'm bringing in, bacteria, and most of that gets caught in the upper respiratory tract. But some of it may make it down into the lungs, and in that case, the alveolar macrophages gobble that up and take it away. We also have a substance called surfactant. Now, surfactant is a soap, basically. Uh, Dawn is a soap, gets grease out of the way. And the way it does that is it makes water wetter. Now, the reason that's important, we are relying on surface tension on the outside of the lungs to inflate our lungs. But the whole surface area of the outside of the lungs is only about as big as a pillow. On the other hand, the surface area inside the lungs is about half the size of a tennis court. So we've got a lot more surface area that is wet. And if we had the same kind of surface tension on the fluid outside the lungs and the fluid on the inside of the lungs, then the structures inside the lungs could stick together, and ultimately we wouldn't be able to expand our lungs because everything would get stuck. So we have this lipid molecule that makes the water in our lungs less sticky. It actually gets in between the water molecules so that they don't adhere as well, and essentially breaks the surface tension. Without that, it is very difficult to breathe, and in fact, neonates prior to about 28 weeks do not produce surfactant. At one time, this was anything born before 28 weeks was considered incompatible with life. Now there are artificial surfactants that can be introduced into the respiratory tree, and babies can be born at 22 or 23 weeks now and still survive. The process of getting oxygen to our tissues is actually multiple steps. There is ventilation, which involves just moving air in and out. And that is distinctly different than respiration. Respiration is the gas exchange. So know the difference between those two. Ventilation is just moving the air, but respiration is the exchange of gases that occurs. Now we have internal and external respiration. And external respiration is the exchange of gases between the outside air that we breathe in and the blood. There is also internal respiration, which is the exchange of the gas that's in the blood with the tissues of our body. We've seen this image before, but it is offloading carbon dioxide, onloading oxygen. That is the external respiration. Now, aside from we've said external, there's internal, and then we also have the act of ventilation, and there are two phases here. We inspire, that is, we draw air in, and that's inhalation, and then we expire, or breathe air out, and that's exhalation. Now, the inspiration portion of our breathing, that takes muscles, that takes energy. The expiration, well, it actually just relies on the elastic tissues in our lungs. Our lungs want to go to their smallest size. So the last thing that you do when you die is to let out the air that's in your lungs, and essentially you have expired. So that's where the term comes from. Now, just again, the mechanics of breathing. Ventilation, that's just a mechanical process. It involves changing the volume in the thoracic cavity, and then with those pressure changes, gases will move to equalize it. So if we make our chest cavity larger, we've lowered the pressure so outside air can force its way into our respiratory tract. When we relax those muscles, what happens is that the pressure within our lungs increases and material flows outward, or oxygen flows out. Now, inspiration involves several sets of muscles. The big one is the diaphragm. That one is at the base of our rib cage, and that muscle tightens up. It's a dome-shaped muscle, and as it tightens up, it flattens out and increases the chest size a little bit. This is what we use when we're just at rest breathing. The other set of muscles are intercostal muscles, and they contract and actually change the shape of your rib cage. That will increase air flow, and we activate those when we are becoming more physically active. Now, you can take a look here, and what we have is that if we are inspiring and we use those external intercostals, you don't need to know external or internal, but what it's going to do is it's going to rotate the rib cage upward, essentially expanding our chest size. And it can do this to a significant degree. We'll talk about how much in just a few minutes. Expiration, like I said, is a passive process that just relies on the elastic tissues in our lungs. Now, the elastic tissues in our lungs decrease or weaken over time, so we don't breathe out as readily or as easily as we age. We do have some additional muscles, and if necessary, we can activate those to force even more air out. So when you've got your big birthday cake with all the candles on it, you take a big breath and you blow as hard as you can, and you are forcing some additional air out beyond what would just go with the diaphragm. When we do this, as you can see, we can collapse the rib cage just a little bit. Now, aside from moving air in and out, there are some things that are non-respiratory in nature. We are familiar with these, I'm sure. I think everybody has experienced these. Coughs and sneezes. They're for clearing debris out of the lungs or the nasal cavity. A cough will clear debris out of the lower respiratory tract. A sneeze clears the nasal cavity. Crying, that's emotionally induced, and I'm not sure what the advantage there is, but we've all had the kind of crying. Laughing, also emotionally induced, but a different type of response. Laughing is generally a truncated fear response. That is, we are surprised by something, and for just a second, we catch our breath, and then we let it go forcefully, so we can relax. Basically, all humor is about pain, and it's better when it's someone else's. So we laugh when we see someone else get hurt, and we think about, thank goodness it wasn't us. So that's basically the base of slapstick comedy and all of that. Hiccups, that's a protective mechanism as well. The diaphragm gets a spasm and we draw in air a little too fast. And so to prevent us from drawing debris into our lungs, our glottis closes really suddenly and we just catch our breath. A yawn is a very deep breath, and it serves a purpose in that it increases the oxygen level in our body. When we're building up too much carbon dioxide, as happens when we sit still for too long, then we end up taking this deep breath to clear our lungs, clear our bodies of the carbon dioxide, and to get a little more oxygen into our tissues. And so this is the end of the second portion. We'll pick up again in just a moment.